Dr. Muralidhar Joshi, and I don't think anybody in this audience or the fraternity of anesthesiology in India requires to know who is Dr. Muralidhar Joshi. He is the most popular personality, and a few things about him. I would like to say that he is a trendsetter. He's always been the first for many things. Right now he is heading the pain department in Citizen Hospital, Hyderabad. So his first, some of the first things that he has done is the first Android application in the world on the interventional pain management, first to start the fellowship in pain management in India, first author for the textbook of pain management in India, first to start the e-learning, and one of the important achievement is he's got the Academic Excellence Award. And there are innumerable achievements for him, but I think now we'll just have the talk from Dr. Muralidhar Joshi. Otherwise, we'll finish the duration only in saying about his achievements. So over to you, Dr. Muralidhar Joshi.
Thanks for those nice words, Dr. Pratibha and Dr. Kumar. Some of them are true, some of them are not so true, but anyway, it's our feelings and of course, thank you so much. And morning everyone. Of course, it's coming to Mysore is always a pleasant thing for me because it brings my childhood memories, because as kids we used to come here for witnessing Dasra. We used to come in the red bus over here, sit over that near Bunny Mantap over there on that particular platform. I think there's some disturbance on life. All the lakes, wherever you go, invariably you will have this kind of birds and all. Beautiful place and beautiful people. Namanadu, Gandhada Nadu. That's what we say about Mysore online. Well, coming back to the scientific thing, recent advance in interventional pain management. Of course, not only this intervention, of course, the word is slightly different. Actually, people might say this way, that way. Intervention can be medications also, doesn't have to be only needles. That's what I'm trying to say. You intervene in the body. It's basically physiology. That's what it is. Yeah. So of course, it's the next incident is a common cold. Life expectancy is going up. Of course, the quality of life is one thing. Of course, pain and early warning. That's what we keep saying. Often manageable provided help is sought. Evidence-based medicine. Question most important is how do we manage all these things, conditions? One thing is I would like to say, let's look at interventions in two components. One component happens to be I would like to say the diagnostic ones, or probably whatever the needling you want to do it and all. Somebody can switch on the timer, otherwise will keep on talking. Thank you. It's not on, that's one. I will keep on talking for next 1 hour. That's one. Yeah, thank you. No, it's on. That's fine. Thank you. So it's very important for us to understand. One is diagnostic one. Second thing is medication or intervention. Diagnostic one, I think you must be hearing these days about artificial intelligence. Must be hearing about it quite often. Actually, it has already started. It's not going. That's not that it's going to come. It has already come. I don't know how many of you really used AI-based ultrasound machine. Have you used anybody? Have you used artificial intelligence-based ultrasound machines? Have you used? Right? Already it has come. It's not that it's going to come. It has come. It's just a question of course, they're trying with only initially with three kind of interventions. Right now, they started with. I would like to say, I think it's from Philips, I think, G, I think, G, and for brachial plexus block, axillary block, and also for femoral. Like you put the probe, moment the plexus comes into picture, it identifies. Here the brachial plexus lies. It's good. You got my point. What I'm trying to say, it's not that it's going to come. It has come already. But problem, I am happy one way, fine, okay, fine. But for me, other way around, what happens here is, if I am a beginner, I am starting my post-graduation. If life is so easy, the day I don't have machine without AI, I become a nut. Because because say for example, these days even we don't remember our wife's phone number also. Because it's there in mobile. Sometimes I think your spouse mobile number, emergency number, the conference people ask, alternate number. Again you have to confirm the phone. It's the same number as what is my wife, what exactly. If not, it should not be somebody's wife's number then. Then that becomes a big problem for me. So AI based has already come. Only for three they come right now. Right now, whatever I have seen, maybe I don't know, it might be coming. That is an amalgamation of almost about 10,000 to almost 1 lakh ultrasound images clubbed together. Normal variants, everything they put brachial plexus, relation to interjugular carotid, and out of scaling the muscles and all those things. The moment you put the probe there, it starts saying, here is the location. So that's what my friend says, it's not only intervention, no newer thing has come, but definitely diagnostic thing, what we had to understand, already it has come. And about the interventions and all, of course, many things have been tried out for time immemorial, from this time, that time, and all those things. But it has been happening so many. These are the conventional interventions, what you might be seeing it. But the most important thing I would like to say is, what we are seeing now is probably some of the specialties might disappear from the horizon. Like, something like you talk of surgical oncology. Because now see, you have liver tumor, you have to take out the liver tumor. Now the question what has happened is, now the chemotherapy tagged nanoparticles, they straight away go and attack the tumor, and there is no need to take out the tumor, you are tagging the tumor. So the question here is, surgical oncology specialty itself may disappear. Look at the way it's going on. So it looks nice from a distance, but when you look at the long-term prospects of the newer things what has come, it's very difficult. The second thing what has come out these days is, what I should say is regenerative therapy. Regenerative therapy. Actually, stem cells were actually they introduced in with big noise about 3 or 4 decades back in US. But it so happened they wanted to regenerate the disc. They injected the stem cells and all. It so happened in one of the clinical trials, clinical studies, one of the patients developed 3 tumors in one disc. One from ectoderm, one from mesoderm, one from endoderm. So 3, like the question here is, same disc, just because stem cells injected. See, some of the stem cells are, of course, they're all like, they can get modified. They will take from the umbilical cord. They can get modified into any structure, as such, of course, and all. And they injected stem cells into disc, and a person developed 3 types of malignancy in one disc. Then US put a big, said no, the funding was stopped from the government of US. Again, they started recently. Of course, there are 2 kinds of, I would like to say, regenerative therapy looking at it. One is what is available in the environment, like for example, methylprednisolone is available, right? Then the triamcinolone is available, then PRP is available. These are all available already there in the, what I would like to say, the environment. There are some things which are from biologics. The biologic happens to be the mesenchymal stem cells. A lot of work is going on. Again, they restarted the work and all those things. They are expecting results, but initial days are there. Of course, I cannot really say that it's going to, how much it's going to make a difference in the long run. Nobody can really predict, especially. But sometimes there are claims and like counter claims. Some people do it this way. Some people claim that there's very good results and all. But as per the Cochrane review and all those things, as of now, they say very little evidence. If not much is available. Another newer thing, what exactly has happened, of course, this is the imaging what you're seeing about the trigeminal neuralgia, whatever we keep in there, or what we used to do earlier with injecting alcohol and phenol over there in the foramen ovale. Now we are putting a needle over the radio frequency. We are able to precisely offer lesioning only of ophthalmic division or maybe mandibular division. We are able to do it. That's all because technology and imaging, that's which is available, which is quite good. Other things is like, the gated channels. It could be sodium gated channel, could be calcium gated channel, potassium gated channel. These are 3 things they're exploring the medications for this one. And sodium gated channels, actually they came with NAV 1.4, 1.5, 1.7, but they got stuck at 1.7. For some reason, the results were not as expected. It was not expected. Like in halfway through the study, they got stuck and all those things. Again, the studies being reworked. But voltage gated channels, they are going to make a difference. And other one is, yes, like we keep seeing quite often in the post-operative period about some people responding very well to the, I would like the subarachnoid block you give, and for some people diclofenac works very well. For some people diclofenac doesn't work at all, and the patient keeps on crying with pain in the post-operative period, and you don't know what exactly it is. And that happens because we see our hypothesis has been that, like, what are the analyses what we normally use? Diclofenac, okay, paracetamol, maybe opiates, maybe steroids, even if you want to take it that way. What else? 4. Local anesthetic, okay, 5. Anything else? Done? But that's called as inflammatory soup. Inflammatory soup. They have isolated 25 inflammatory mediators. 25 inflammatory mediators. That includes complement, that includes interleukin. So if I am a predominantly interleukin secretor and you give prostaglandin inhibitor to me, how will I get pain relief? So the work is about the like molecular this thing and all this. They're looking at. Then that means we have to develop anti-interleukins. We are going to a fixed idea like I'm going to use the prostacyclin inhibitor for this group of patients, and for this group of patients I'm going to use this one. Opiates also, like for example, biggest challenge for especially in not only here world over is biggest problem with opioid is about the abuse. So somebody might use it for recreational purpose, right? And we have natural opiates which are supposed to be there, and we have got synthetic opiates. We talk of synthetic opiates with natural opiates, we derive the synthetic opiates from the natural opiates, right? But what is happening here is, for example, if somebody is getting addicted to the opioids because of the recreational whatever benefit he feels, how about taking that component from that particular molecule? So we have to get the industry, take out, okay, for example, opioid, the question here is, somebody has got osteoarthritis knee, but doesn't want to go for surgery, for their own choice. But should they suffer from pain? Why are you not able to put opioids? Because there are side effects, okay. At that age, maybe you may not feel, you might feel that, okay, opiates can cause addiction. Okay, somebody at age 60, 70 years, okay, it doesn't matter, or maybe it's okay. But question here is, their kids can get addicted to that one. Because it happens, especially in the oncology, probably Dr. Amrita will certify that one. But sometimes it happens for us, like palliative care and all, some patient dies. Once the patient dies, all his medicine basket is still lying at home. And what happens, like, then once somebody starts using that one, opioid, leftover fentanyl patch, I got back pain today, let me use a patch. Why should I waste? That's actually, classically it happens in Indian household. Almost all ladies, I'm talking men at all, only women I'm talking, because they are the last person to have dinner at home. They're the last person to have, most of the families, 99%, I don't think any other family. And what happens, sometimes we go to party and come back, I'm not hungry. I'm not hungry means he's become angry. And the question is, the food will get wasted. Just because food is getting wasted, she finishes that food. That's why women gain weight, not for any other reason. Not that they eat more, because question, we are not disciplined ourselves in our home, they tend to gain weight. So similarly, when the medicines are left, we have seen quite often, okay, what was this? This was for cancer pain my father was using. Any I got joint pain, let me use that. Once you start getting used to it, then sometimes subsequently what happened, only if the patient's son comes, like my father wants a pain medication. That's where all the morphine tablets and all those things we say only prescribe only for 1 month, not more than that. In some states, less also. And always, in case patient cannot come sick and all, we always try to speak to the patient. Make me speak to your father. That time, that also they did. Sometimes they met somebody, they called up somebody else, but he's my father. So you have to keep on cross questioning and all those things to understand. But I'm just giving an idea. So addiction liability is there. So how about taking out addiction liability from that one? Okay, constipation one thing. Take out the constipation part. You think like pruritus is one problem, side effect, take out that one. So the question here is the opiates, study designs are being changed. So that opiates are good because no end-organ effect, no renal effect, and of course for the liver also it's okay, by and large glossly okay. So that is one thing which is going on. And it's not only medication that is being offered. It's not only medication that is being offered, drug delivery systems also. That is changing. It's not that newer drugs are being designed. Newer drug delivery systems are also being designed. The question, what happens, simple thing, I keep on telling you so often, like it happens. Say for example, like you do a surgery, fine. Post-operative pain, what are you going to do? Say you might put if patient goes to the ward, you're going to put a diclofenac sodium or something like that, and you tell to be given 8th hourly, intramuscular, because patient cannot take orally. At 10 o'clock at night, patient will be sleeping, the sister goes and taps, get up. No, I have to give the injection to you. That injection will be more painful than actually surgical pain sometimes. So, like to avoid this one, what they are devising here is, how about having a diclofenac? I don't know how many of you, of course, probably senior generals, they know. We used to Vicks Vaporub, remember? Vicks Vaporub. Like we used to apply over the chest and used to inhale and all, like mother used for cough and all, something they used to do. Or Amritanjan, apply here. But again, it's a classical case. You should understand Amritanjan that I'm not promoting the company. But for headache, Gendobom and Amrita, what you use, it's a counter irritant. Use it when you have headache and use it, it's a counter irritant. You start feeling better. Use it when you don't have headache. Have you tried anything? You should do all these things. Otherwise, how will you become a pain physician? Try out all these stupid things and all this. Then only become a good clinician. You start getting headache. If you use Amrita when you don't have headache, you'll definitely get headache. And here, that is what, for example, now, if I put a patch here, diclofenac, and I keep on inhaling it, and it patches for 24 hours. Fine, it's only for patient local delivery. For local problem, local solution. You keep on inhaling like Vicks VapoRub. And why should I give an intramuscular injection? That's one. Second thing that is what they're working on, that one is, you know, postoperative pain. Where is the postoperative pain normally? If I do laparotomy, postoperative pain is in the abdomen, right? Yes or no? Over the incision, that area and all, maybe visual pain little bit. How about having like you remember the mesh, like sutures, problem, they put a stitch and all those things. Sometimes they put a ventral hernia, they put a mesh and all those things. Imagine if I coat a mesh, a small mesh like this thickness with, I should say, maybe paracetamol, diclofenac, right? And opioid, right? And I put it in the abdomen over the skin layer and I stitch it. And local pain, for local problem, local solution, why do you want to give systemic, oral, or maybe intramuscular or intravenous? So that is one thing which is working on, that's going on now. And you put it there, it gets absorbed in 10 days. But 10 days any posterior pain will go off and cost almost comes to same. So that is one thing you might be expecting in the near future. And the third thing, which is one more thing, what they are looking at here is, the biggest problem in the pediatric group. See, postoperative, like in sometimes we give suppository and all under, when patient is under anesthesia. Subsequently, it's very difficult. Child may allow, may not allow. Or sometimes some child has fever. Probably something like what Madam was saying about post chemotherapy induced pain and all those things, and then you have to give some paracetamol or something like that. Every time it happens, whenever you want to, if a child has a fever or something like that, and you want to give oral this thing that the pediatrician prescribes, don't give antibiotics, give only paracetamol. Because it could be viral fever. That's not practice. What happens here is sometimes after 3 days the fever still persists. Then you give the antibiotic also and paracetamol also. Then whatever you give syrup form with great difficulty. Doctor tells give the medications after feeding the baby. Right? After feeding the baby. Now what happens next is you feed the baby. Okay, fine. Baby has been fed. You give antibiotic. With great difficulty, baby will be crying and all is have it. Finally, you give paracetamol and child vomits. Right? Child vomits. Now you don't know how much antibiotic is inside, how much is on the floor. Right? After vomiting, the child starts crying. Because child is crying, mother will cry. Once mother starts crying, her mother, grandmother starts crying. The grandfather doesn't know, he'll go to balcony and father goes for a walk. After half an hour, again same drama continues. Again they mix the food and all those things, again prevent all those things. To prevent this, what they come with new paracetamol is, it will be wafer kind of thing. Because you have to give liquid syrup and all those. Wafer, just put it in the mouth, it dissolves. But we can't do for all the molecules. That's what they're doing for other molecules. But we can't do it for all the molecules because it all depends on the weight of the molecule. How many Daltons to make it wafer. You can't make it for all tablets, all molecules. But these are somewhat like, I'm telling you, it's not only I'm talking newer medications. I'm talking newer drug delivery systems also. This also came with a lot of promise. Epiduroscope. In fact, I used to do it earlier, quite regular earlier. After that, I don't do it much. Basically, idea was, why was this discovered, like was being used was, if you remember probably people who have passed out in some 90s or something like that, the list, OT list used to be like that. GJ vagotomy, GJ vagotomy, GJ vagotomy. If seniors can remember that, GJ vagotomy. Now if you just look at the list, lab chole, lab chole, lab chole, lab chole. Now what happened to GJ vagotomy people? Where did they go? What exactly happened to them finally? Because we had subsequently like ranitidine, cimetidine, and of course proton pump inhibitors. Those things reduce that one. And second thing, we didn't have endoscopy at that time, and we didn't have ultrasound. Once endoscopy came, every upper abdominal pain, we used to think of GJ vagotomy. But once we got the endoscopy, we could do endoscopy, see that the stomach is fine. So why GJ vagotomy? Then ultrasound came, then we could pick up the gallstones. So once the gallstones are picked, then that's how the whole thing changed. So for everything, you need some, this epiduroscope, what we are using it for if endoscope can change so much for probably the abdominal surgeries and can bring, why not epiduroscope? We thought, how about using epiduroscope and all in the back for going to epidural space? But if you just understand the dimension of epidural space and all, this epiduroscope, it has to go through the caudal canal. When you go to caudal canal, you are the dorsal part of epidural space, while the disc is the ventral part. That means you have to hook around the thecal sac. But if you want to hook around thecal sac, there are chances that you might end up with a dural tear. Dural tear. And second thing is, even best of the best centers in the world, it has to be in the operation theatre, not in the side room of endoscopy. It has sterile. It takes 45 minutes, minimum 45 minutes. Now what are, so diagnostic point is because otherwise what you see over the lymphatics, right? What is the epidural, dorsal epidural, lymphatics and blood vessels, maybe you can see some nerve roots on side and all, but definitely disc cannot be seen. But of course, as a subsequent development and all those, you know, people are doing transforaminal endoscopic discectomy and all those things. That work is going on. So the question here is, every discovery, every research may not end up with a great results, but definitely it's going to make a change. Of course, CT guided procedures and all those with imaging assistance, the way you use GPRS to reach this particular location, where is exactly the conference hall and all those things. Similarly, you can use the same thing for CT guided navigation for these procedures. So these are, and then radio frequency lesioning is one more thing. Earlier, for neurolysis, we used to use earlier for alcohol, phenol, or glycerol, something like that. Now these things are like something electrocautery. I would like to say electrocautery, where you can really, you can go about using electrocautery. Where you can, only thing electrocautery, you don't take control on the temperature and the duration, but here you can set that temperature and duration. And of course, one more thing, like isotope scans and all, quite often being used in the pain medicine, where exact sometimes MRI may or may not show the cause, but active what you see in lesions over there in the facet joints, you can see that one. Spinal cord stimulation, it has been there 1960s onwards. Only thing is the electrodes are being changed. So what was there, only about 4 electrodes, now there are becoming 8 electrodes, and all those things. And second thing is now there is peripheral nerve stimulation also. That was their planning, that one, not only just the question on going for spinal cord. And of course, these are the, you can see the black lines, what you're seeing dots over there. There are nothing but, of course, active electrode. You can select a group of 4, top 4, bottom 4, middle 4, you can activate so that you can identify where exactly the pain, and you can replace the, I should say, the or the stimulus, what you want to, whichever part. How can this intrathecal, of course, drug level systems, but molecules are less for opioid, intrathecal opioid system. We have only ginconotide, or maybe I should say lignocaine is one thing which we use, and opioids is one thing, but we don't have many molecules and all. But again, a lot of things are changing now. Advanced neurosurgical interventions, the vertebroplasty, percutaneous cordotomy. Of course, these days, the one more thing is non-invasive cranial stimulation. Non-invasive cranial stimulation. Non-invasive cranial stimulation. Can it be Amritanjan also? Non-invasive cranial stimulation. They are putting something like headphone kind of thing, stimulating here, and many migraines and all those things, because medications have a lot of side effects. So that is one thing. A lot of centers have come. It's not, I'm not saying that it's not theory. Centers have come up already here. So many things are there for interventions when you do it, and the advantage is non-allergic benefits are the limitation of side effects, improved quality of life, and of course the weight gain can be avoided. Less sedated, alert, and satisfied patients can be there. But combination of therapy is much better than anything else. But sometimes it may not work that much. So I would like to think it may not work up to as per the expectation of the patient, if the patient wants to become all right or not. To conclude, most important thing is newer things keep on coming. If you're not still convinced, buy some time. Don't be a trendsetter in your home, and don't do any harm. Follow your protocol, weigh the risk and benefits. Of course, select the patients, let patient earn the intervention, update yourself, whatever this thing. So this kind of innovations and future trends, they keep on happening from monkey till the latest man. So it keeps on happening though. Now for like Coke, you're talking about having that one, like other day I see some whiskey also, whiskey tablets are come now, capsules. You don't have to whiskey like this. Capsule either just put it in your mouth and you're done. Yeah? You can try that one in the conference. You can tell the organizers. Thank you so much once again for patient hearing. Thank you.